So how well do you understand what occupational therapists do on a day-to-day basis? I know for me, I didn't really understand the breadth of what occupational therapists did and the breadth of their training. We'll talk this week with Megan Osgood Doyle. She's an occupational therapist who's leading an interprofessional pain program up in her neck of the woods. She's doing some amazing things up there, and she's going to share some insights on what occupational therapy is, what it does, and how it can be of huge benefit to our patients in pain. We're going to talk a lot about some of dysautonomic regulation stuff and some different things that she works on in her practice. We'll talk about some of our cringe issues we have when it comes to this psychosomatic term where pain is either organic, real, physical, or non-organic in your head, in your mind, where we know pain doesn't work that way. It's all of it at every moment in any patient, acute nor chronic, obviously to varying degrees depending on the situation. So this podcast is full of a lot of pearls to better understand where occupational therapy fits in the grand scheme of healthcare. For those of you who are occupational therapists listening to this episode, you will hear some call outs to occupational therapy education and things we need to do that isn't just unique to occupational therapy education. It's definitely something that we all need to improve as far as healthcare education as a whole. But the episode's full of good tidbits. Hope you enjoy it.
This is the Modern Pain Podcast with Mark Cardula.
Megan, welcome to the podcast.
Hi, Mark. It is so great to be here and finally get to have this conversation with you. Been really looking forward to it.
Well, it's good to have you on. It's always good to have our occupational therapy colleagues. I think occupational therapy and PT, we're good friends. We should be better friends, I think, and we'll talk to that this episode. And some of the lack of awareness that the general populace has on, I think occupational therapy probably has it a little bit worse than even physical therapy as far as that. And we're going to work to solve that issue as much as we can today. But Megan, I've had the pleasure of getting to know Megan a little bit through her work online, but also through some of her training through Evidence in Motion with Adrienne Lowe's program, the Therapeutic Pain Specialist program. And she's done even much more, which we'll talk about today. But before we get into that, Megan, do you mind introducing yourself to the audience?
Yeah, not at all. So I have been an occupational therapist now for over 10 years. I practiced in a ton of different settings. I've been in true acute care, inpatient rehab, subacute, long-term care, and as outpatient. And I practice here in Boise, Idaho for a really large nonprofit health system. Really excited to share that just recently, at the beginning of this year, I transitioned to a new program as our rehab program manager for our outpatient pain program, both as that program manager, but also providing the occupational therapy services. So really excited that I can now focus on just pain treatment from that biopsychosocial model and really growing our program here, but also have that background. In the past few years, I focused a lot on treating pain holistically in more of an inpatient subacute setting. So I love the fact that I have that passion and have had that application across these different practice settings, and I hope that comes up in our conversation today.
Oh, absolutely. Absolutely. And it's always interesting to hear some of the great things that our guests are doing. And of course, you're doing some awesome things there. I love the fact that we're seeing systems get pain programs up and running, and having some of our clinicians who have great expertise in pain, and occupational therapists definitely can carry that expertise. And we'll talk about some of the things you've done to move your expertise up the ladder in that and become somebody who's, highly respected and really has a great knowledge base. And the folks that get to see that program or get to go through that program are lucky to have you guiding the ship. But before we get into that, I think it's important that we kind of help the general population. Probably some of the physical therapy folks that are listening to this podcast is probably more of our audience, but we do get some OTs and other folks who are interested in pain. What sets occupational therapy apart as far as other healthcare professions? I think it's probably one of the more underappreciated and misunderstood professions out there. What kind of sets OT apart from others?
Yeah, well, that is a great place to start because it's kind of this interesting double-edged sword for our profession. We are an incredibly holistic and very big and broad profession, but I do think that does cause a bit of not confusion per se, but then just not quite sure how to nail us down. And so a great place to start is understanding what does occupation even mean? Because of course the joke that still is around, or I'll work with clients and they'll say, well, I'm not working. I don't need a job. So the definition of occupation is what occupies our time, the things we need to do, want to do, or are expected to do in our daily lives. What's really incredible and kind of what sets us apart is that we look at all these different areas of a person's daily life, like I said, that they need, want, or are expected to do in areas of occupation. So occupational therapy has our practice framework that was developed by our national organization, American Occupational Therapy Association. Keeps getting updated all the time, as it should. And the most recent iteration, the Occupational Therapy Practice Framework 4, divides occupations into 9 different areas, including activities of daily living, which people are probably a little bit more familiar with. So that's more, getting dressed, grooming, getting ready for the day. But also I want to mention the fact that that includes sex and intimacy. And I think that's something that doesn't get thought enough about in the rehab space. But occupational therapists have the training to help individuals with returning to sex and intimacy, whatever that looks like for them. There's also instrumental activities of daily living. So that would include areas like driving, taking care of the home, but also that includes religion and spirituality as something that, of course, is important to people. Work is its own area of occupation. I love the fact that sleep and rest is its own area of occupation. And goodness knows, if you're working in the pain space and you're not addressing sleep, you need to be doing that. Otherwise, you're doing a gross disservice to the people you work with. Also, leisure is its own area of occupation, and hobbies. Play is its own area of occupation. Also, social participation. So we know that social is huge in the biopsychosocial model of pain. So love the fact that that's its own area as well. And then another area that's newer is actually health management. So health management would incorporate looking at how somebody responds and manages their stress. How are they able to incorporate either physical activity or formal exercise into their daily routine? How are they managing overall diet and nutrition? So there's all these different areas that we can focus on. We really focus on not only being very person-centered, but also problem solving. How is it that that person can engage in all of those different areas? And then especially when it comes to pain, we know pain would affect or be affected by all of those different areas. So we really look at this from that big picture lens for that person. And we try to use those occupations, not just as a goal for treatment, but the treatment itself. So that's where if I'm really living up to that scope, I'm trying to implement and work with somebody in those actual areas or address those areas as best as I can.
Yeah. So I think that's, and as I've had the good fortune to work with a lot of OTs pretty much throughout my career, I've been in clinics with OTs side by side, and it's always been great to rely on the expertise. And it's always interesting the lack of awareness that even some physical therapists have and the general public has, but such a valuable team member of the healthcare professional team for sure. And I think you really laid out a lot of the amazing things that OTs can do to help our patients along. And you kind of touched upon this a bit, but I'm just would like to kind of hear your thoughts on how you feel like occupational therapy and kind of our current understandings of pain and the complexity of it, and kind of where you feel like those two are a good kind of fit together.
Yeah, absolutely. And that I really need to kind of go back to the beginning a little bit. For those who don't know, physical and occupational therapy as brother-sister professions were born out of the same time period. We were born out of World War I with soldiers returning home. I'm actually an Army wife myself. And so when I was going through my occupational therapy program, that was resonating with me on such a very deep level. I thought, wow, here these professions were born. We were referred back then as restoration aides. But one of the things that always struck me, and obviously want to get to why we know this is so applicable for pain, is during that time period with soldiers coming home, having what was called at the time, of course, shell shock. Now that's, we know that's a different version of post-traumatic stress disorder. But it really speaks to the fact that it was always about that mental and behavioral health aspect. So recognizing that engaging in things that bring value to our lives helps that behavioral and mental health. And now thinking about how occupational therapy was always trying to operate within that biopsychosocial model. So something that is kind of interesting is that we think about the biopsychosocial model of pain, but the biopsychosocial model is applicable to any and all populations. And so for an occupational therapy practitioner, and when I say that, that means both an evaluating occupational therapist. We also have occupational therapy assistants. So we kind of group them together as occupational therapy practitioners. And that aspect of that biopsychosocial model, really recognizing that there's always that mental and behavioral health aspect. And for occupational therapy practitioners, for a long time back in the day when there were more of these, outpatient type or even inpatient, especially chronic pain programs, occupational therapy was always at the table alongside physical therapy, other mental behavioral health providers like pain psychologists, counselors, psychiatrists. And then unfortunately, what came along was third-party payers breaking up that party and siloing all of us. And so I think that's a little bit of the background as to why maybe it's not as well understood, or even occupational therapy practitioners themselves don't quite understand what our legacy or our history was when it comes to treating pain. But now recognizing that if we're working with somebody different than a psychologist or a counselor or a psychiatrist would, but an occupational therapist is going to look at how is this person's pain affecting and being affected by, first and foremost, their mental and behavioral health. One of the things I enjoy in my practice and occupational therapy practitioners do learn about are psychological or psychotherapy concepts like cognitive behavioral therapy, acceptance and commitment therapy, which has really, really come on the scene, not just in persistent pain treatment, but more research is showing its efficacy actually in acute care and acute pain treatment. We're going to incorporate that in the context of those different occupational areas, like I mentioned, and then really helping somebody with their overall self-esteem. Self-compassion is a huge area. And then helping them recognize that there is this beauty in trying to participate in those things that they need and they want to do, things that bring them joy, value in their daily lives, a sense of accomplishment. Because when we go to modern pain science and we think about things like the fear avoidance model, which is one of those things that's kind of turned into the bedrock part of that biopsychosocial model, helping people engage in those things that they enjoy doing, feeling that sense of accomplishment puts them more on that side of recovery versus what we know individuals being more in that unfortunate cycle of the fear avoidance. So we're going to look at it more in that occupational engagement type side and incorporate those different psychological and social pieces. Another thing that occupational therapy practitioners do very well is look at the intersections between the person, the things they want to do and need to do, but also the environment, which we know from that biopsychosocial model is really important. Certainly the physical environment, but we know how important the social environment is. So recognizing those social dynamics, which a lot of times can really be the drivers for that person's pain persisting. They don't have good social support, or they're very socially isolated, or there's just a lot of familiar work or other types of stress dynamics. We know that ultimately that can lead to that autonomic nervous system dysregulation and have that person be more with that sympathetic overdrive and not able to tap more into that parasympathetic. This is where, polyvagal theory and other theories really come in. So there's all these pieces that both, physical therapy, physical therapists, mental behavioral health providers, other providers can all speak to. But the difference being that occupational therapy, like I shared, is going to really look at it within the context of that person's lived experience and is going to really incorporate all those pieces into those very real activities that they want to be able to do. And then the amazing thing is, lo and behold, when they're able to start to do those things, well, then naturally their pain is going to start to get better because we know that that threat perception is going to go down. This is where, looking at the pain neuromatrix and also the mature organism model is so important. And then I love sharing with folks that they're like, oh yeah, when I started to do these things, I really felt better. And pain neuroscience nerdy me goes, well, that's because your body started to make its own natural feel good because you were going out and getting coffee with a friend, or you were able to clean the house today the way that you wanted to, or make a meal for your family, or spend time with your grandchildren. So using those as an actual pain treatment and incorporating, again, the mental and behavioral health aspects from that biopsychosocial model and the social and physical environment, it's really complex because pain's really complex, but occupational therapy is that profession that can actually really look at every single piece for that person.
Yeah, no, great, obviously, contributions. And I think you laid out a really good kind of background of all the things, especially within pain, where an OT can really excel and be a very valuable team member, especially in programs such as the one you're running over in your neck of the woods. You mentioned a little bit of like sympathetic system, challenges, autonomic system and some of the polyvagal theory things. This is me nerdy, wanting to kind of pick your brain a little bit because I'm always interested. I'm a definite, like we see, especially folks obviously with POTS and different things where systemic dysregulation can get really. And then obviously there can be other conditions relating to that. And you mentioned also polyvagal theory. We have a friend here in Tucson, Matt Erb. You probably know Matt. He's very in tune with polyvagal theory and mind-body type connections. I'm just curious kind of your approach or maybe some things you kind of consider when we're looking at like dysautonomia, autonomic system dysregulation in regards to folks that are obviously in a distressing, identity-threatening situation that pain can be.
No, absolutely. And that's a perfect segue because that lets me speak to this other piece that I really wanted to bring in that occupational therapy practitioners can really bring to the table when it comes to pain treatment. So occupational therapy, our scope of practice, another thing that we focus on is sensory integration. And what's interesting is that in my career, I've always practiced in adult settings. Sensory integration in the occupational therapy space most of the time, and this is where I would caveat, this is unfortunate, and this is if there's OT practitioners listening to this, hey, we need to do this in the adult space with these folks. Sensory integration gets incorporated a lot with children. And that is where, whether it's children that have been identified as being on the autism spectrum, neurodivergent populations such as ADD, ADHD, but even other diagnoses such as OCD. And this is where this starts to cross over into some of those psychiatric diagnoses as well, such as post-traumatic stress disorder, but then also bipolar. And so talking about that autonomic nervous system and polyvagal, we need to also talk about that mind-body connection, internal sense of interoception. And so interoception is truly that mind-body connection, that self-regulation piece where we recognize, I'm feeling my heart race, I'm feeling my muscles tighten up. For those of us that have that more regulated autonomic nervous system, so sympathetic and parasympathetic systems a bit more in tune with one another, we can recognize in our bodies, oh, I must be feeling more stressed. I can do something about that to address that from a healthy perspective. I can do my deep breathing. I need to calm down. When it comes to something like polyvagal theory, and certainly the clientele that I have, unfortunately, we know from the research, and more is coming out, but research such as, with adverse childhood experiences, the role that especially childhood trauma, but then compounded as well with traumas that occur in adulthood, this is where we start to see with polyvagal theory how if, all is well in that sense, an individual can feel really safe. And we know safety is so huge. It's that opposite side of the threat perception when it comes to pain. That's where people can be mindful, be within their bodies. They have that really good sense of mind-body connection and that interoceptive awareness. And that's when we see sensory systems like sight, feel, touch, hearing, vestibular system, all within balance. What can unfortunately start to happen, especially from a trauma-informed perspective, is that when that fight or flight response, but then again, for a lot of individuals, especially in childhood, when that nervous system is just first really developing and getting influenced, we can even go down a path to what's called freeze, and that's more of that disassociation space. So what I have found in working with the individuals that I do that are identifying that significant history of trauma, but then also doing all the reading on polyvagal theory, this is where I have to put a plug in for a resource like The Body Keeps the Score by Vander Kolk. If you're in the pain space and you have not read that book, I would highly encourage that you do. It is incredibly instrumental to understanding the role of trauma in pain neurophysiology. And so what we find is that just from a protective standpoint, that nervous system response and that disassociation, in order to just be so protective, just becomes so dominant. And so these are where individuals are having that effect, not with persistent pain or more centrally sensitized or nociplastic type reported pain or widespread, but this is where you're also going to have individuals report things like an inability to recognize even when they have to empty their bladder or bowel. This is where we see those comorbidities of irritable bowel syndrome, restless leg syndrome. This is where we see, issues with cardiac, pulmonary hypertension. So that interregulation with the immune and endocrine function. So we know that pain is one output with this whole overall system, like from the neuromatrix theory, but then all these other outputs and bodily systems are influenced, and they all regulate and influence each other. And then from that interoceptive awareness, if that sympathetic nervous system is like really in overdrive, somebody's really in that survival mode, I will educate them very simply. I'll say, hey, this system is set up and designed to protect you from this internal body awareness. It's going, hey, we don't have the luxury or time to pay attention to things like hunger cues because that digestive system is so affected with that HPA axis or gut-brain axis. We don't have time to know when we need to go to the bathroom or not, and all these different things. And it's amazing to work with individuals. A great outcome measure to use for this, there's a couple really good ones. One is the central sensitization inventory, because it takes into account a lot of those different pieces that are related to this autonomic nervous system dysregulation. But from an interoceptive awareness, there actually is the MAIA, which is the multi-assessment of interoceptive awareness. And that can ring really true for a lot of people and has some questions on that questionnaire that relate to pain. So if somebody just pushes on through or they ignore the signals. And so it's just really interesting about recognizing that that role of trauma and what that is doing to this nervous system response. But then also recognizing that once we know that for individuals, that is actually changeable, and that's where we can give that hope to them.
Yeah. No, I love what you shared there as far as some of the strategies you're using for some of that. That's a challenging population, and I use kind of similar strategies, to kind of get folks to be in tune with it, that, our bodies aren't meant to be, running on fight or flight that much. But you mentioned the opposite side of the coin where the body can go into, freeze and feign and different things like that. And I'm hoping we can start getting better and better. I know obviously our discussion is, hopefully evidence that PT and OT are thinking of these things and incorporating. I just see, obviously there's healthcare challenges of traditional biomedical approaches, really seeing the forest for the trees, which I know I'm preaching to the choir with you on that front. And that's probably why you're engaging in the program and leading the program you're leading there, which is, obviously going to be a huge benefit to the community where you're at. My other thing that I'd be curious to see your thoughts on would be one thing that I almost cringe a little bit. I'm sure I struggle with, and I'm not sure where psychology falls in your program. I'm guessing there's some sort of involvement. There's still, and I've been fortunate to get to know a lot of amazing psychologists, but we all know that pain psychology, I always joke and say it's like trying to find a unicorn in the wild. There's just not a lot of pain psychologists to be found. It's apparently not a very popular pursuit in the psychologist, professional world, which, it's a challenging population. Don't get me wrong. It's just a lot of emotional challenges and things that can be taxing on, obviously, our patients first and foremost, but the practitioners who are trying to unpack some of that challenges with people. But this dichotomization of somatic and psychosomatic, or non-somatic, or organic and non-organic, which I cringe and I still struggle with. I'm curious, what's been your experience with that? As far as, have you experienced it in your practice, when we're working with other healthcare professionals who might try to cordon people off to that? And what's your thoughts on it? And then maybe what do you think we need to do to stop that dichotomization of humans, where it's either this or that, where it's all of it at all times. It's just varying degrees of contributions in these things. But I'm curious what your experience has been with that.
Yeah, no, absolutely. I cringe too. I really do cringe at that phrase of psychosomatic. And it's really interesting because, and this is where I think this is our great call to action, and why both occupational therapy practitioners, physical therapists, and PTAs belong in this space, because we do work with the body and we need to bring the mind along. And so we can be this unifying group that kind of helps the other professions recognize, hey, one profession maybe has been a little too focused on the biomedical, maybe some more of those providers. But then what you're speaking to, Mark, is that maybe psychologists for a long time have been too focused then on the mind, and then not being able to address, hey, like, how does this interconnect with the body? I've been very fortunate in the different practice settings that I've been in, especially having practiced in these acute care and inpatient rehab settings, to come across more often in my career at this point, licensed clinical social workers. I think personally that licensed clinical social workers, especially counselors or LCSWs that have training that in trauma techniques, but in particular, this is where, learning about something like EMDR. So my bias at this point is it could be a role for pain psychology. I would agree. They're kind of turning into unicorns, and there's very rigid kind of traditional cognitive behavioral therapy techniques and implications that have been shown to be beneficial. And then also more practitioners in the psychological pain space I had mentioned earlier, I do have a bias. I enjoy incorporating acceptance and commitment therapy because I think that values base really lines up with the OT scope of practice. But like my wish list for this program that I'm now running, if we do get our locked in, behavioral health providers, actually a licensed clinical social worker with, for instance, training in EMDR. Just because that's more about that mind-body sensory, this is where the polyvagal comes in, that trauma reintegration. So I would like to think that there's some more of these models where there are these other behavioral health type providers out there beyond just, maybe a trained pain psychologist that can actually be a really great member of this team and provide these different techniques. That the evidence base for EMDR at this point is incredible. And I have some clients that have actually had EMDR treatment and have just told me the incredible benefits of it and the efficacy of it. So it's interesting. I think maybe we need to look broader and kind of educate our other mental health care providers. I have had some good conversations with more in the psychology space about things like psychosomaticism and giving them new, information on pain neurophysiology. So the other ask would be, if we have this integrated team from an interdisciplinary perspective, I think we can agree that at a bare minimum, what needs to happen is that we're all speaking that same language and having that new understanding of that mind-body connection. And then make sure we have that dedicated mental or behavioral health provider that can really provide that right treatment. So now my new unicorn is getting the counselor in here that has the EMDR training more so than a pain psychologist.
No, I love what you said. I think the same language thing can be such a challenge, and when you get healthcare that tends to cordon people off into there's, an ologist, an immunologist, an endocrinologist, the psychologist, the physiologist, all the different things. And I always, talk to patients, like, you got a bunch of people telling you different things about one specific tree in your very complex forest that somebody needs to talk to you about the forest. And I think we can do that as PTs and OTs. And that's literally, I think, the biggest things I do is connect the dots for people on all this stuff. This is why you've been shuffled and you're getting all these different diagnoses and different things. And you got people giving you a different label that makes sense in the tree they understand, which I would argue is just labeling it the same systemic complex human dysregulation with, again, different language, which furtherly confuses the situation, which, as you've probably experienced, and I know I've experienced, just patients who are just completely lost and frustrated and have no clue what's going on because they're getting all this different information thrown at them. It's interesting. Social work, I think that's a great profession. I've had the fortune, been fortunate as well to get to know some, not recently, but he's very skilled. And we'll link some of the EMDR stuff just to kind of, for those of you who are wondering what that's all about and maybe looking at, how that might fit. We'll link that in the show notes so you guys can check that out. A little bit of a segue, but similar, because I think there's some discussions where this stuff and students too in our university are thinking, well, this pain science stuff, it's just for chronic pain patients. It's just for those folks who are 15-year sufferers of chronic pain, and of course it is very applicable to them. But apparently, pain happens acutely too. I've understood where people have acute injuries, and lo and behold, they actually think and behave uniquely about it. Some people obviously more adaptively, some people probably more maladaptively. But I wonder if you could speak to a little bit about the challenges where this belief that, this better understanding of pain is only going to be applicable to these chronic pain patients, and where you see acute pain and how you may intervene in that situation and recognize acute pain where, whoa, there's some things going on here that I need to interject, or maybe some acute pain where you're like, hey, everything looks adaptive and let's just support you and let natural history in the body do its thing. I'm just curious where you fall on that.
Yeah, absolutely. And that's where, the past few years, when I first moved to Idaho and started with my current health system, I'm an outpatient clinician through and through, even though I've had those other practice settings. So I had really wanted to get back to outpatient, but I saw it being good fortune with my passion about just the treatment of pain, not these specific types of pain, just pain, that I did have those few years where I was more in that inpatient acute care type setting. So really getting to work with those individuals pretty soon after, whether it was an injury, accident, surgery, things like that. So yes, this is where it still kind of boggles my mind that people almost get a little, I don't want to say afraid, but a little leery of providing pain neuroscience education or explanations to individuals that are going through an acute pain experience, because they're like, well, but there's real tissue damage, so how do I explain this? Pain is always operating from that mature organism model, pain neuromatrix, the biopsychosocial model. What I advocate for, and I'm super passionate about, I wish we could say that we can completely prevent any new initial acute pain transitioning to persistent pain. That could lead us down a whole other path. I think you would appreciate, Mark, of talking about things like epigenetics. And, this is where there's those great researchers, Balakai, where they looked at how we'd probably have to do brain scans of everyone and see like how much limbic system cortical reorganization they have. So that gets pretty far into the weeds. But some of the things that we know is that somebody's understanding of their pain, certainly fear avoidance levels, and then their overall coping, and if they can operate more from that internal locus of control versus external locus of control. All of those psychological and social factors are completely at play, from, the simplest quote unquote ankle sprain to another type of population that I quite frankly am super passionate about working with and think that this is super important. Individuals after catastrophic, orthopedic type injuries, individuals that have been in motor vehicle accidents, and we're not talking just straight whiplash. This is where obviously we're talking about, multiple body region fractures and things like that. And these individuals are finding their ways into not just that acute care hospital setting, but then going through maybe more intensive inpatient rehab. And so what you have is this opportunity in those early weeks of that person's recovery to influence these things in a very positive way. One of the first things we can do better when it comes to educating on pain in that acute state is educating somebody how pain works. So this is where, even though we know that there's more of a bio component, and there's always a bio component present, doesn't matter if pain has persisted for decades or not, it's just wondering what's the piece of this pie that's being more the driver. I'm sure everyone listening right now can imagine having worked with somebody where, maybe they had a hip fracture is a great example. Had a hip fracture, ended up having surgical fixation, and they're reporting significant pain levels, and they really don't understand quite what's going on. Maybe they've been told that their weight bearing is tolerated, but understandably, they don't quite understand what that means, or they don't understand that, yes, you are safe to put weight through your leg. That's actually how our bones will eventually heal. by the way, when you start moving, that's going to help get blood flow. Your nerves around the area of that fracture right now are a little bit more sensitive to movement because everything is healing, and it's just letting you know that. So trying to incorporate that pain neuroscience education in the context of education that we already provide, and also making sure we're doing it in a supportive and validating way and not a patronizing way. So I would always educate someone. I would say, of course, this seems really scary. I mean, you just had this fall and a fracture that goodness knows you weren't asking for. That's that psychological piece. A lot of times there can be feelings of shame or guilt. I can't count the number of times that, somebody was older and like fell off a ladder. Then they're chastising themselves. How I shouldn't have done that. That was really stupid. My family's, berating me for getting up on the ladder. So if we don't look at all of that person's kind of things that are feeding this biopsychosocial model, another way to think about it is almost like how a virus would operate. So what we want to help somebody have is not have this host where pain is going to want to take up residence and continue to live, if that makes sense. So this is where we want to help with having those positive pain cognitions for individuals, that pain is not the enemy. Yes, your body's healing after this acute injury or even an acute onset of pain that is stemming from significant stress. We know that's also very possible. People have significant pain with no measurable tissue damage, but it's an acute onset due to what's going on with that nervous system, stress hormones, chemicals, things like that. So helping people in order to feel safe to move, recognizing what's actually going on with their bodies, making them feel hopeful that, yes, you're healing from this injury, but you're going to go on to be able to do, all the activities that you want to do. It's just going to take this timeline. And then providing that education as well, where, I know you're feeling some more soreness, but we want to help you try to be able to tolerate that. So it's more about kind of that tolerance and threshold and just having this language with folks, and really people recognizing that, wow, you know what, you're right. I get more pain when I feel myself get really kind of scared about going to put weight on this leg. Or, you know what, you're right. I didn't realize that I was holding my breath, or that I am feeling more stress right now. And I didn't get a good night of sleep last night in the hospital. So my leg is feeling that more today. I don't think those things, thankfully, take too long to provide those explanations. But when we take the time to make those unknowns known and help somebody actually understand their own body, that's where we're providing that self-efficacy. And that's where, if we do that right in that space, not to mention we can teach people different techniques like focusing on deep breathing. I have loved educating people in the hospital on doing guided body scans or meditation. This is where you can even incorporate graded motor imagery with acute pain, which I don't think gets talked enough about either. There's so many cool studies. There was a randomized control trial from 2018. I apologize that I don't have the authors right off the top of my head, but they looked at doing things like explicit motor imagery, visualization, even mirror therapy in patients with a distal radius fracture. And the group that did more of those mind-body strategies with the graded motor imagery had better outcomes than usual care. They had more range of motion. They had more strength. They had less pain than the group that didn't. So another thing I think that happens, and Mark, I bet you would agree, I don't understand even why we're not just dividing the mind-body, but we're trying to still say that there's ortho treatment and neuro treatment, when even in an acute pain state, the nervous system is completely at play. So we can incorporate some of those neuro aspects in order to be more proactive and preventative. And the research is actually starting to really show the efficacy of that.
Yeah, no, I am full in agreement that I think, and I actually had a conversation yesterday, it's probably going to be a podcast of a few episodes before this one, with Matt Lowe about how our professional boundaries are often limiting our ability to help people. Not saying that we don't need our own space, but I do definitely question sometimes when we get, just like you said, an orthopedic treatment where it's only looked at through an orthopedic lens, which isn't how pain works, unfortunately. Pain is always psycho, neuro, immuno, musculoskeletal, endocrine, immuno. You could probably list off all the things that are going on and kind of fluctuating based on the unique situation and the unique again, we can go into epigenetics and,
Yep.
and genetics. And I mean, you and I could probably nerd on this stuff for days on end, but it's just some of the lack of consideration. And again, I alluded to it earlier. It's just this understanding the forest because that is what often is the key. I think you'd probably agree with me, is trying to unpack the forest of complexity of childhood trauma, of all these things that may have created the situation or fed into the current human in front of us that has a hard time processing, sensory processing and doing all these different things that we can treat. But when you can help people see the dots connect and how that kind of has influenced the nervous system that developed when they were kids, and how the nervous system and autonomic system struggle to regulate when trauma's been part of their past, or the traumatic experience that they're going through now, losing their identity and their ability to be the person that they used to know looking in the mirror, who's kind of foreign person to them these days. It's just so powerful if you can kind of get all that stuff in play and understand that there is no you alluded to the acute chronic pain, false dichotomy that exists, is that there's only psychology involved in biology and social. I mean, all that stuff's embedded in a unique human context that person lives in. And it's full of psychological beliefs. It's full of past experiences. It's full of, like you said, epigenetic changes of how their nervous system and body systems have formed in relation to the life that they've been exposed to leading up to that situation. Again, we can get into complexities. And with that said, I'm curious, I haven't really talked a ton to my OT colleagues as far as where education is like at the entry level with OTs. I know in PT, we're doing our best to push the envelope of getting folks to be more aware of persistent pain. I honestly think OT has been probably ahead of us as far as you've been thinking of cognitions and different things well beyond PTs. I remember when we thought we were just groundbreaking. I was talking about this stuff and my OT calls, we've been doing that. We taught that in undergrad. And I'm like, okay, so before I really understood all the OTs have a huge understanding of a lot of this stuff already. I'm curious how you see OT education as far as where that's coming up, and maybe if you could wave a wand and have the OT curriculum the way you'd like it to be. I know I have my thoughts in the PT world, but where's OT education at? Obviously there's some strengths, as we've already mentioned. There's probably holes as within any profession. Where do you see that in your profession?
No, absolutely. That's a great topic, because this is also my call out to my profession. So I feel like a lot of times when I'm standing on my soapbox and advocating, I'm advocating for the understanding of occupational therapy in the pain space, but I'm advocating for my own profession to realize to do what's needed. So there are holes. There are some really big blind spots. It's really quite fascinating. So one of the things that occupational therapy we do really well is like I shared, we've always tried to focus on the biopsychosocial model, and it hasn't ever mattered, the population. It's just anyone we work with, because we're looking at all of those factors. And, it's interesting. I've been out of school now for over 10 years. And even, back then I had an entire course that integrated mindfulness. One of my professors, that was his research focus. But did I ever hear mindfulness applied to pain? I did not. And that riddles my brain now, because occupational therapy, our standards of practice, our accreditation standards include a heavy focus on mental and behavioral health, a heavy focus on psychosocial interventions, understanding the psychosocial dynamics. Pain was a little bit of that, but this is where I think the holes that need to be filled, Mark, and this is where I know there's that crossover. More physical therapy programs making pain neuroscience education part of their curriculum. I don't see that yet with occupational therapy programs, so it's a huge blind spot. Because then what I see happening is occupational therapy practitioners coming out of school knowing to address mental health in these certain spaces, or we should do this, or we know different types of stress management techniques or relaxation or all these different things. And then not just acute pain, but then also chronic pain, we try to masquerade like other professions. And so I've had other conversations with my physical therapy colleagues where this weird blind spot for OTs, where they'll say, well, with chronic pain, we'll do, some joint protection and make sure you're following biomechanics, and we'll do some modalities. it's this weird blind spot all of a sudden where I think what happened is once we kind of lost our way and the biomedical model infiltrated that a little bit, it's like treating pain more from that biomedical model when I'm trying to tell my colleagues, like for OT, no, guys, we do the biopsychosocial stuff, especially that psychosocial, really, really well. We look at the behavioral mental health. We do mental health clinical rotations. You need to be doing this in the pain space. It doesn't matter if it's chronic pain. It especially also matters if it's acute pain. You need to do those different interventions. So to me, that's my call out to OT, and that's what I would wave my magic wand. We need the pain neuroscience education and the updated pain neurophysiology in all the programs, and I know all healthcare needs that. But then I need those programs, and I've gotten to do guest lectures for the different OT programs that are here in Idaho. For their psychosocial courses, and saying all this great psychosocial intervention you're learning, you need to apply it to pain. Do not do these modalities. Do not do these passive treatments. That is not what we do. So that's this weird blind spot. And that's obviously, you can hear it. That's clearly my other area of passion, where I just scratch my head, and I want to make sure that our scope of practice is applied to that space. It's this weird blind spot that's got to be addressed.
Yeah, I can definitely relate to some of the blind spots here. I think sometimes we default to just biomedical because that's just kind of where our training is kind of dovetailed. I'm working to do some lecturing and different things in our neck of the woods as well. And it's a struggle because there's still a lot of traditional things taught, which we have to. There's some accreditation standards and different things. I think the speed at which research and current evidence and things hit textbooks and then thus hit the university floor and lectern is always a little bit, way slower than I'd like it to be. I think if we could more rapidly disseminate evidence and incorporate it into current, and I just don't see how with current technology and things we couldn't do that a little bit more quickly, but that's maybe another episode. Maybe I'll get somebody from CAPD, our accreditation body, is like, why the heck does it take so freaking long to get evidence into the classroom? To where we stop teaching things again, we're teaching some good things. Don't get me wrong. I know OT programs are doing amazing, DPT programs. There's a lot of variables at play that I think sometimes can make it very challenging, which I get, and I've been exposed to myself. So, Megan, I want to respect your time, and we could, like I said, chat a bit about this. And I always enjoy talking to you. I always learn something. Talking to folks like yourself come out better than when I went into the conversation. So I appreciate your time today. Before we finish today, I'd just be curious if you don't mind sharing where folks can find you, like if they want to check you out on whatever, LinkedIn, Twitter, Facebook, wherever you feel like would be a good medium for folks if they want to get in contact with you.
Yeah, absolutely. And you're going to link all the socials too in the notes, yes. Right, Mark? So definitely can find me on multiple social media platforms. I am on LinkedIn. I use my full name, Megan Osgood Doyle. So you can find me on LinkedIn with that. Also on Facebook, Megan Osgood Doyle as well. My Twitter handle is at @MOsgoodDoyle, and I'm also on Instagram as Megan Osgood Doyle as well.
Perfect. So definitely check out Megan's social feed. She always is sharing some good stuff. And you can't tell she's passionate at all today. Hopefully, she really seems pretty low key on things. No, it's great to have folks like you working in the pain space, not just for OT, but just for pain in general. I think we need to multiply and conquer, which it's a work in progress. We got more work to do, more folks to hopefully get into this information. Hence why we're doing this podcast, is so hopefully those of you who are listening, this might have stimulated a kick in the rear of maybe we can do a little bit better, and hopefully you all will do better in your neck of the woods to help your community out, who are full of people that are probably struggling. I know it's not hard to find folks that are dealing with some challenging pain situations that, some better information and some better healthcare could do better with. But Megan, thank you so much for your time today. I hope you have a wonderful rest of your day. Thanks a ton.
Thank you so much, Mark, for giving me this opportunity. The conversation I knew was going to be fantastic. It did not disappoint. And yeah, I agree. I hope that people are spurned on and are influenced by this. That's my hope. I want people to know that they can do this, whether it doesn't matter what practice setting you're in. We know you're working with people with pain, and, we have that capability to do better. And the individuals we work with deserve that. They're looking to us to give them that hope. And for especially physical and occupational therapy practitioners, we are well poised to be able to do that for them, probably better than most, to be honest.
Well said. Well said. Well, thank you so much again, Megan. For those of you who are watching on YouTube, don't forget to subscribe so we can get this information out to some more folks. On the podcast, if you don't mind sharing a little review or something, that way we can get this more pushed up the podcast meter so folks can, again, get exposed to this information so we can help more people. But until next time, we'll talk to you guys all next week.